In this video, we'll be talking about randomized trials. Our learning objectives are to distinguish between observational and experimental studies, identify the defining features of randomized trials and group trials, explain why randomized trials are considered a gold standard for research in public health, describe potential limitations of using experimental designs, and finally identify potential applications of randomized trials within healthcare systems. So just as a reminder, let's talk about observational studies. Cohort and case controls were the two major designs we talked about previously. And in these, we take a sample from our source population. For a cohort, we exclude people with existing disease and then divide people who are free of disease at the start of our study into exposed and unexposed groups, follow them over time, identify incident cases of disease, and then compare these incidence rates to calculate a relative risk. In a case control study, we still take a sample from our source population, but instead we divide these people into cases and controls and ask about their past exposure and calculate an odds ratio as the measure of risk, comparing these two groups. So in observational studies, we're just watching what's going on. We allow people to naturally divide themselves into exposed and unexposed groups and just measure their experiences. Conversely, in experimental studies, we as the investigators intervene and actually assign people to an exposure group, typically randomly, in order to evaluate the associations between exposures and outcomes. So randomized trial is the most common type of experimental study that we use in health-related research, and it's a comparative study of two or more interventions on a given outcome in which the participant's exposure is determined by random chance. So the exposure is some form of a new treatment, and the unexposed group is given some sort of control measure. So that could be a placebo, the current standard treatment, or some comparison treatment. So in public health, randomized trials are used. This picture showing a bed net study, so providing bed nets to people in areas with high malaria prevalence to prevent transmission to children. So that's an example of a public health randomized trial. We also commonly think of using randomized trials in drug studies, so pharmacoepidemiology and other types of drug studies often use randomized trials. And the basic layout of a randomized trial is shown here. So you still start with a sample from your underlying population. So that's the same as in an observational study. You still want to make sure that that initial sample represents the population that you're trying to evaluate this association with. Then you invite people to participate. There will be some non-participants and then the group of people who agree to participate. So first, we want to make sure that we don't have selection bias here. We want to make sure that our non-participants aren't systematically different from our participants, making our participants no longer look like a representative sample of our underlying population. So once we have our group of participants, we randomly assign them to either the intervention or control group. So by randomly, we mean without respect to any personal characteristics or disease characteristics. So this is really the strength of randomized studies, the fact that we are assigning exposure without looking at their other characteristics. And so this really limits confounding, because in theory, by randomizing exposure across groups, we're also randomly distributing any confounding factors. So we don't need to worry about them as much as we do in observational studies. So after randomization occurs, we have our intervention group that receives the treatment that we're testing and the control group that's receiving the placebo standard of care or some comparison treatment. And then we follow people in both groups over time to measure the outcomes. And along the way, we may have people who drop out of the study, die, or leave for some other reason, and those people are called lost to follow-up. And so again, we want to make sure that those that we're losing to follow-up aren't systematically different than people remaining in the study. So this could be another source of potential bias when we're comparing our outcomes between the two groups. So it's important to measure those people and know what the reasons were, if possible, that they left the study early. So we always have inclusion and exclusion criteria in randomized trials. Once we have our research question in mind, then we establish these criteria. Often they center around demographic characteristics and health or health conditions. So it could be something related to the disease or other types of disability, cognitive function. And these should still allow us to generalize our results to a broader population, but might be important for understanding what the actual impact of the treatment itself is without worrying about interference from other kinds of conditions. Okay, so we've talked about randomization. A placebo, which you may know is just an inert substance that's designed not to induce any sort of effects of treatment. There is what's called the placebo effect, so people who are receiving sham treatment or care can still have a benefit because of contact with the healthcare system. So it's important to note that that might be an issue in a randomized trial. But in general, we still make comparisons between placebos and treatment groups, and the placebo should resemble the actual treatment as closely as possible. And it's only acceptable to do this if there's not a standard treatment available. So it would be unethical to assign people to a placebo if we know there's already an effective treatment available. So in those cases, we just do a comparative effectiveness study where we're comparing the new treatment to the existing one. Blinding is a nice potential feature of randomized trials that can also limit bias. So this is all about concealing the subject's exposure status. So we have what are called single blind studies where the participant doesn't know whether she is in the treatment or control group. Double blind studies are those in which neither the participant nor the researcher or analysis team knows the participant's exposure status. So again, this just helps make sure that measurements are taken consistently and that people aren't inadvertently collecting data or interpreting results in a way that leans towards the experimental treatment. As I mentioned before, it's important to track people along the way and understand why they're lost to follow-up. The reasons this is important is, again, because it might induce bias into our results if people are leaving in a systematic way. It could also impact the power of our study. So typically when we design a study, we want to make sure that we have statistical power to detect associations. So if we end up with a smaller sample size than we anticipated, that could certainly reduce our power. And we also want to know if people were leaving because of adverse events related to the study medication or treatment, whatever that might be. So recording adverse events is an important step in a randomized trial to allow us to make decisions about balancing risks and harms of potentially new interventions. And finally, when we're measuring the outcome, we want to make sure that we're using clinically or statistically relevant endpoints, and they should be defined at the beginning of the study. So it's not unusual to have a primary outcome and then potentially some secondary outcomes. But again, those should be listed a priori and then evaluated consistently across all study participants. So should make sure that all evaluators in the study, if more than one person is evaluating the outcome, they should all receive the same training to minimize misclassification bias. Ideally, they would be blinded to the participant's exposure status. And you also want to make sure that you don't have one evaluator, for example, assessing all of the exposures for the control group and another doing all of them for the intervention group, because that could result in differences across the two evaluators that look like differences attributable to the treatment itself. So best to have, if there are multiple people, they should be assessing outcomes in both treatment and placebo groups. So here's an example of a randomized trial. This one was looking at whether oxygen helps with preventing pain associated with cluster headaches. So cluster headaches are really intensely painful headaches that occur on one side of the head or neck and can have other symptoms like runny nose and runny eyes. The current treatment when this study was done was treating with drugs, and there was some use of oxygen, but this study was really designed to evaluate whether high-flow inhaled oxygen was more effective than a placebo for acute treatment of headaches. So the investigators did a randomized, double-blind, placebo-controlled crossover study on 109 people. And a crossover study means that people serve as their own controls. So they've received both the treatment and the placebo. So we'll come back to that in a second. Here are the inclusion and exclusion criteria for the study. It was only among people age 18 to 70 who had been diagnosed with cluster headaches, and they were excluded if they had migraines that couldn't be distinguished from their cluster headaches. They excluded women who were pregnant or lactating. They excluded people with COPD, since oxygen therapy is a common treatment for that condition. So the end, as one of their later exclusion criteria is that you can see here, they excluded people who had previously tried oxygen treatment for cluster headaches. But they also, part of the reason for the COPD exclusion would be to exclude anyone who is currently using oxygen for another reason. And finally, they excluded people who couldn't wear the oxygen mask. So pretty reasonable set of exclusion criteria, which is good because this means that the results are likely to be generalizable to a broader population. So the study design, and here is the crossover part again. Participants were all given 2 tanks. One had air in it and one had the high flow oxygen. And they were told to alternate the tanks for each treatment. So each time they had a cluster headache, they were to use one tank or the other. And the tanks weren't labeled, so this was part of the blinding. They just probably had numbers or letters on them so they could record which one they were using, but they didn't know if it had air or oxygen in it. And they used diary cards to record their symptoms at 5, 10, 15, 30, and 60 minutes after the treatment. The primary endpoint in the study was being pain-free at 15 minutes after treatment, and then there were several secondary endpoints, being pain-free at 30 minutes, reduced pain at 15, 30, 45, and 60 minutes, a need for additional medication to treat the cluster headache, the response to the treatment and any functional disability associated with the headaches, and then effect on other symptoms like swelling, nausea, and restlessness. So the results were that 78% of the oxygen treatment group and 20% of the air treatment group reported being pain-free at 15 minutes after treatment. So this is evidence that oxygen was more effective than air in treating cluster headaches. The relative risk, if we compare these two crudely, just dividing 78 by 20%, is 3.9. So that means that people who received the oxygen were about 4 times more likely to be pain-free at 15 minutes compared to people who received air. And there weren't any adverse events reported in this study. So one of the major reasons that we don't use randomized trials for all of our questions in epidemiology is ethical concerns. So there are a number of things that we need to think about. The first, as we've mentioned, is whether it's ethical to randomize people to a placebo or to a standard of care treatment. But we should also make sure, assuming that it's ethical to do the study, we need to make sure that participants understand the various factors that are related to randomized trials. So the first is the protocol itself, what they'll be expected to do. But the second is randomization, so understanding that it's random chance whether they get a new treatment or the standard of care or placebo. They should also be educated about alternative treatments, potential risk and benefits, how their information will be kept confidential, whether or not they'll be compensated, and then who to contact with questions. Finally, all participants in research studies always have a right to withdraw, and so it's important to make sure that participants understand that. Even though we as researchers would like to minimize loss to follow-up, we want to make sure that patients feel comfortable withdrawing from a study whenever they want to. So far we've been talking about randomized trials in the sort of traditional sense, which is an individual level randomized trial, but it's also possible to do this at the community level, so group unit of analysis rather than individuals. And an example of a community trial or a group in a community randomized trial would be something like a school district, a city, a county. In the context of health services research, it could be a clinic or a ward within a hospital. And so in these trials, we randomize groups to exposures rather than individuals within those groups. So it can be used to test an etiologic hypothesis or the impact of a program or an intervention. We still need to consider the ethical factors that we would consider in a randomized trial and a group randomized trial. The major challenge with doing group or community trials is finding communities that are similar enough to compare them. So again, we're randomizing whole groups of people, and so it can be challenging to find groups that are similar in other characteristics that could reasonably be served as comparisons. We also need to think about in and out migration. So depending on how long the trial lasts, we could have a substantial number of people entering or leaving our communities, and that could influence our results. And finally, we could have the ecological fallacy. So we didn't talk too much about ecological studies in this class previously, but there are a class of studies, of observational studies, where we look at groups of people. And the issue there, the ecological fallacy, is that we could see associations that hold and are true at the group level, but don't translate to the individual level. So that's a potential limitation of community trials as well. So here's one hypothetical example of what a community trial might look like. If we were interested in evaluating whether we could reduce low birth weight in communities that have a health educator and a smoking cessation program for pregnant women, we could use a group randomized design. And that might look like choosing one community or potentially several communities that were randomly assigned to begin a new smoking cessation program for pregnant women and have a new health educator available in the community, while others would just operate as usual. And then we could compare the rates of low birth weight across those exposed and unexposed communities. So these are really useful trial designs when we think that things like social constructs, social norms, law enforcement, retailer practices are likely to influence the effect of an intervention. They're also a good idea if we think that it isn't really possible to randomize at the individual level, if we think there will be spillover. So that's essentially when we are concerned about the person getting the intervention, that those effects would then spill over to friends and neighbors, for example. So other people might hear about it from them and get interested and change their behaviors as a result. Or if it's something like a health educator, there just may be naturally people who are in the unexposed group who end up getting services or information from that health educator in other contexts outside of the study. A potential benefit of community trials is that you could reach more individuals with the exposure than in an individual level trial. So again, in this example, using a health educator, it could benefit the entire community in other ways than just low birth weight, and it could also benefit more people than just the individual sampled to be included in a specific study. So in summary, the benefits of an experimental study design are that it gives us strong evidence of cause and effect, largely because much of the confounding that we would worry about in an observational study is eliminated because we randomize. We can frequently use a larger sample size and have a larger public health impact than we could in an observational study. And we can look at dose response, so we could intentionally deliver different levels of exposure to evaluate whether or not the outcome increases along with the increase of exposure. Drawbacks are that they can be very costly and time consuming. It can be difficult to recruit people and to keep them in the study. We often are limited in terms of ethics and what we can randomize people to. And again, in community trials or group trials, it can be difficult to find comparable groups. Within the healthcare setting, randomized trials can be useful in two broad categories. The first is the kind of traditional individual level preventive and therapeutic trial. So doing comparative effectiveness studies to look at whether the current treatment is as good as a potential new treatment. And in those, we can look at both patient outcomes and cost effectiveness to help us make decisions about which programs and services to offer within a healthcare system. The second class of studies that we could do in a randomized fashion within healthcare systems is more along the health services research line and organization of care. And these could be individual level or potentially group levels. So this is looking at things like team composition. How do we provide the best team-based care? Excuse me. Doing task shifting. So looking at whether nurses or nurse practitioners, for example, could do some of the tasks traditionally done by MDs, if that would be effective in terms of patient outcomes and cost effectiveness. We could also look at different payment reimbursement or incentive systems across different clinics or providers. So again, this is where group trials might be a good idea to look at things like payment and reimbursement. It may not be possible to randomize within a clinic across providers, but we could randomize clinics. Randomized trials can substantially reduce confounding and provide strong evidence of effectiveness, but keep in mind that samples should still be selected to represent the underlying population. Ethical issues limit the use of randomized trials in public health generally, but they're frequently appropriate in healthcare systems, both for patient care outcomes and for care organization evaluations.